Hi guys, this is going to be blood disorders lecture, and we're going to be talking about three of the disorders that we cover in adult: iron deficiency anemia, aplastic anemia, and polycythemia. Before we get into iron deficiency anemia, I kind of want to give you an overview of what is anemia. And so let's kind of get started with that. Anemia is a disorder or a issue, a problem with the blood, and it could basically be caused by three things. It could be an issue with the number of red blood cells, or the quantity or quality of the hemoglobin. And let's kind of review what the hemoglobin is. The hemoglobin is what carries the oxygen molecule. Or it could be the volume of the red blood cells with, we kind of say the hematocrit. Um, Anybody can really suffer from anemia if they experience different things. For example, it could be because they lost a lot of blood or they had some surgery, which they say is secondary anemia. So, anemia as a result of the blood loss from surgery. It could also be because the deficiency of the red blood cells during the production of them. So they're not being produced how they are normally being produced by the bone marrow. Or it could be that the balance of production versus destruction of these red blood cells is not equal. So, meaning we're destroying red blood cells more or faster than what we are being producing the red blood cells by the bone marrow. Um, we typically diagnose anemia on a CBC, a complete blood count, with a hemoglobin in a hematocrit level. I really highly encourage you to kind of know those numbers. It's different from male and female. So, how does anemia manifest? Well, honestly, manifestations are really due to the lack of how much blood loss is happening, or the severity of the blood loss, like how quickly it is. And then any other coexistent diseases that the person might experience. So, for example, if you have someone that has respiratory issues and now they're also anemic, they might show more of this shortness of breath and fatigue, versus someone that is healthy, is young, doesn't really have any comorbidities. Maybe they don't experience the shortness of breath as severe. There are three different levels: mild, moderate, or severe. Um, and so the level is there. Hemoglobin from 10 to 12 is mild, 6 to 10 moderate, and less than 6, you're talking about severe anemia. Now, I do want to tell you that some people might experience moderate symptoms at a hemoglobin of 10 or 11. It just, again, it depends, what they, um, kind of what their body's doing. In addition, someone might have some mild anemia and they might not even have any symptoms. They might not even know that they have anemia. For example, a perfect case of that is me. I went to donate blood and I found out I was anemic. I had no clue. And it wasn't because I went to donate blood that they took my hemoglobin that I found out I was anemic. So some of the symptoms and signs for mild could just be palpitations, shortness of breath, and just feeling tired. Moderate, you might have the palpitations, shortness of breath, and tiredness just at rest, like meaning with no activity. And then when you get to severe, then we're talking about pallor. You're looking kind of whitish. Um, you might have the tachycardia a little bit more. You're going to feel cold all the time, maybe some pale conjunctiva, um, and some dizziness or low blood pressure. We treat anemia in different ways. The first way is that, we really need to know what's causing the anemia. And so, if it's a blood loss issue because of surgery, then, we know it's going to be sort of expected and the body will bounce back. But if you're losing blood because you have an ulcer or you have something bleeding inside you, you need to fix that. We're going to monitor the vital signs constantly. And then we're going to basically make them comfortable. So if they're short of breath, we can give them oxygen because that's what they're lacking. They don't have that hemoglobin, so they don't have that oxygen molecule. We're going to give them a little warmth, maybe IV fluids just to build up the volume within the vessel, give them rest, and then if it's less than 7, this is usually what happens in the hospital. Less than 7 hemoglobin, in the hospital, you get transfused. So you will basically, the doctor will order a blood transfusion. Now, granted, I've seen people that will get a blood transfusion at 8, perhaps. The reason for that is because even though it's not below 7, or below 6, like in severe cases, they're still symptomatic. So we say that anemia being symptomatic, they grant for a blood transfusion if it's really bad. So now let's talk about iron deficiency anemia. So it's still anemia, but it has to do with the lack or the absence of iron. So iron deficiency is a decrease in hemoglobin and iron levels, and we need iron to make the hemoglobin. So in order to create it, to synthesize it, we need iron supplement. Like it's so if we don't have it, then the hemoglobin is not going to be effective. um, Iron is being absorbed in our GI tract, specifically the duodenum, and we basically get iron mainly from our diet. So, and also, let me kind of put a parenthesis here too, so you understand. There's different nutrients that are responsible for creating red blood cells, okay? And some of these nutrients, and I'm just going to list a few of them, okay, um, are your B vitamins, vitamin E, folic acid, iron, vitamin C, and your protein. So if you have a lack of any of these, you might have issues with your red blood cells. But specifically, we also need iron. We get it from the diet. There are different foods that can give you that, and we're going to talk about those in here shortly. It is absorbed in the duodenum. So people that have gastric bypass, they might have issues with hemoglobin. And also, it is better absorbed with vitamin C. And we're going to learn also that here shortly. Some of the causes that can lead a person with to have iron deficiency are maybe someone that has a deficiency in their diet. They don't consume, enough nutrients and or foods that are high in iron. Alcoholism is key. A lot of alcoholic people, they just don't eat, and they basically don't get the nutrients. If you have a constant heavy period, or people that are women specifically that have heavy menstrual cycles or lots of births, like they've been pregnant for a while, they could have anemia as well. All right, so how does it manifest? Well, you're gonna have uh, y- maybe some of the symptoms of anemia, the normal symptoms, or you might not even have any at the beginning. But some that it's one that is very common is being pale. You could have specifically to iron anemia, it's the spoon nails. They kind of concave and shaped like a spoon. You can have glossitis or swelling of the lips, as well as headaches and tingling of your hand and feet. We diagnose it just with hemoglobin and hematocrit. You can get their iron levels just to see how low they are. Then you can also, the physician can order ferritin. Ferritin is this protein that literally stores iron. So if your ferritin is low, then that means your body's not storing iron. So that's why it's helpful in the diagnosis of iron deficiency. Another thing that they can order is this TIBC, the total iron binding capacity. This basically measures like how good is the iron being attached. Um, so in order for it to be transported, it needs to kind of be attached. And so it just measures the ability to attach itself to iron, the blood, so it's also helpful when we are talking about iron deficiency. And then transferrin, which is the transporter protein of iron. And then they might also order like MCV, which is kind of tells you the average size and volume of the red blood cells, as well as some bilirubin, vitamin B12, and folic acid. When a physician is trying to figure out maybe why your hemoglobin is low and there's not a specific cause, what they'll do is just order a bunch of tests just to see if anything is off limits or like it's giving them red flags of where it could be the problem. And one of these exams could be like a stool examination, like a colonoscopy or endoscopy. Worst case scenario, bone marrow biopsy if they think it's a problem in the bone marrow. So it's not like it's just one specific, diagnostic testing. They'll just throw a bunch of things out there just to see if that leads them into, okay, the next exam that I need to order. So once we are diagnosed with anemia or the client is, diagnosed, then what we need to know is, okay, what's causing it? So that way we can treat the cause of it. And some of the things that we can do meanwhile is educate the patient about high iron foods. Okay, so any foods that are high in iron, and you're going to find those in page 719. They're in your book. Um, but just so we can kind of discuss those here, I have a table that we're going to go over, but pretty much it's just your red meat. There's some broccoli. Um, you have like potatoes and stuff like that. Um, you can also supplement iron orally, okay? But however, here's the deal with iron orally. He has some kind of weird side effects, um, or adverse effects, like kind of normal of it. First of all, it needs to be taken with iron because it's best absorbed with vitamin C. So it needs to be taken with vitamin C. It can cause GI upset. So a lot of patients complain that it makes them have heartburn, constipation, or diarrhea. So they don't really like to take it because of that. They can also turn your stool black or this greenish, dark greenish color. And so we wanted to educate our clients that, hey, listen, you got to start your iron supplement, but I need you to know this thing so that way if they happen, you're not concerned. They're going to cause constipation, so you got to take a stool softener or a mild laxative, increase your fluids, increase your fiber intake, and then also know that the stool can turn black or green. Um, Iron is also better absorbed in a acidic environment, and so that is why vitamin C is given, and also why it needs to be taken 1 hour before eating. Hold on 1 second, guys. I got a cough. So yeah, um, we want to make sure that we tell the clients, hey, take it on an empty stomach with vitamin C at least 1 hour before eating. Then, in worst case scenarios, they could get iron IV, and that's okay. The only problem with iron IV is that we have a high risk of allergic reaction. A lot of people tend to be sort of allergic to iron IV. Um, but they can get it, like an infusion at a center or at the hospital. That's another way. And in reasons where their, hemoglobin is so low, then they're going to get a blood transfusion. Here's the iron-rich foods, as I was mentioning earlier, like, it could be your red foods, it could be broccoli, potatoes, some spinach, raisins, apricots, and eggs are high in iron. Okay, let's talk about aplastic anemia. So, aplastic anemia, um, just like this picture shows here, we have a non-production deficiency decrease in all your blood cells, all the components of the blood. So, we're talking about platelets, we're talking about red blood cells, and we're talking about white blood cells. So therefore, and you're not going to have like your hemoglobin is going to be low, so you're going to have all your symptoms of anemia. You're going to have no white blood cells to fight for you in your immunity, so therefore you're more prone to infections. And then you're not going to have platelets that coagulate, so then you can basically bleed. And the term for what you call whenever your blood cells are decreased, all your blood cells is called pancytopenia. Okay, so if you see it or you hear it, pancytopenia, you know what that is. It's basically as a result of a failure in the bone marrow. The bone marrow is like out of order, it's not working correctly, and that leads to no blood cells, red, white, and platelets being produced. So, how does it manifest? Well, it manifests just by, again, no immunity, no coagulation. You might have petechiae, bruising, or nosebleeds, and then all your signs of anemia. Your tiredness, your palpitations, your shortness of breath, etc. And this could happen in a matter of days to weeks to months because as the bone marrow starts failing, then you might see more common the symptoms. All right, so how do we diagnose it? Well, we diagnose it by basically taking a complete blood count where it's going to show you your red blood cells, your white blood cells, your platelets, and then a bone marrow aspiration because since it's a failure in the bone marrow, we kind of need to see the bone marrow, so that way we take a biopsy, we look at it under the microscope, and we can see, well, not us, nurses, but, the pathologist can see that, hey, it's not being produced. Nothing is being produced here. And what we do to treat it is that we do supportive care for all this lack of all the red blood cells, white blood cells, and platelets, and prevent any kind of complications. So let's talk about supportive care. So pretty much we know, hey, there are risks for bleeding. So we want to make sure that we prevent from them to bleed out. So they cannot be getting up in ladders, they cannot be playing maybe contact sports, falling, etc., because that can lead to severe bleeding. Same with immunity. We want to teach them, hey, stay away from sick people, stay away from crowded areas, stay away from um, yeah, maybe hospitals, live vaccines, just because those things are making you prone to infections. And right now, you don't have any immunity to fight for you. For anemia, for the symptoms of anemia, the supportive care would be iron, blood transfusion, most likely, because since your body is not producing any red blood cells, um, your anemia is going to be severe. You might need antibiotics if you develop an infection, but ultimately, hey, your bone marrow is going to have to be transplanted. You might have to get a new blood marrow, and it has to come from a donor that is compatible with you, with the client. All right, the next one is polycythemia. Polycythemia is poly is many. And so when you think about polycythemia, think about many of these cells, where aplastic, it's no cells. Then poly, we have the vascular system is basically um, deteriorating because we got so much going on. So we have a high red blood cells, white blood cells, and platelets. The vascular system, the blood circulation deteriorates, and it does that because of the viscosity and the volume. And it's a problem in the bone marrow. The bone marrow sort of goes crazy and proliferates all these cells at the same time. And so that leads to, the problems that we have. And it's classified as primary polycythemia vera. That leads to splenomegaly, hepatomegaly, and these hypercoagulation issues that we have, or disorders, hypercoagulopathy. So it manifests in different ways. These clients, because they have a lot of red blood cells and a lot of platelets, um, they basically suffer from clots. So think about the viscosity, it gets thick. Their blood gets thick. Plus, now you have more platelets that stick to each other. So they are a high risk of, clots or stroke. Because of the volume, the increase in volume, they could have headaches, vertigo, and dizziness, as well as visual disturbances. The itching comes from the bilirubin because of the red blood cells kind of being extra destructive. And so they kind of the body kind of goes and say, "Whoa, we got too much. We gotta break them down." Or the production of the bone marrow is start producing red blood cells that are immature. They're not developed, and so the body kind of kills them, or destroys them. That's a better word for it. And so it elevates that bilirubin. It also elevates the uric acid, and so that's kind of what the itching comes from. You can also have bleeding, but don't confuse bleeding with not having platelets. Okay, because you're like, whoa, wait a minute. She said the platelets are really high. So why would I have bleeding? The bleeding actually comes from too much blood, too much volume. It just kind of leaks out. And so you could have like nosebleeds, etc. So what do we do for these clients? Well, oh, sorry, before I tell you what we do, how do we diagnose it? We diagnose it on a CBC as well. We can see that the hemoglobin is high. We can see that we have immature red blood cells. We can see that the platelets are high, but mainly it's going to be a bone marrow examination, a biopsy to know that the bone marrow is going crazy here. So now let's talk about what we do for these clients. One of the things that we do is reduce the volume and viscosity of the blood. And how we do that is by removing blood, like through phlebotomy. So these clients go every other day, every 2 days or so, and get blood removed from their body. And then they can go back once it sort of stabilizes. They'll go back every 2 to 3 months. You also want to dilute the viscosity by keep them very, very well hydrated. So a lot of hydration. With hydration, you want to consider intake and output. Okay, so you don't want to be too overloaded with fluid, but neither you want to have the output low, which means that, hey, there might be dehydrated because dehydration, then that means the viscosity is going to increase. You want to prevent complications such as a stroke or an MI or a clot. And for that, we give them antiplatelet medications like aspirin or clopidogrel or Plavix. And these basically inhibit platelets from sticking to each other. Um, these are very common antiplatelet medication, aspirin and clopidogrel Plavix. If the uric acid increases due to the destruction of the red blood cells, then they might get gout medication. A common gout medications is allopurinol. And then, these clients get bone marrow suppressant agents because again, it's the bone marrow going crazy and just proliferating all these cells in a very fast rate. So if we suppress the bone marrow a little bit, then we can fix it. We can help this situation. And there's some medications there that um, commonly prescribed. We want to increase activity or promote activity because of the clot risk, um, as well as, if they're in the hospital, maybe put on sequential devices like SCDs, etc. Or turning them, getting them, walking, getting them to the chair and whatnot. With that also includes the teaching. You want to make sure you teach them what to what to watch out for, and what to look for if they're at home and they might be experiencing a stroke or an MI or a clot. Okay, well, those are the three blood disorders. I hope it was helpful. And my reference are always from the book, and all images are from Google or the book. And I will see you in the next video.